Um, Hello everyone. Now we are going to discuss types of shock, that is table 85.1. There are five types of shock, as we already know. This is hypovolemic, cardiogenic, distributive, fourth is obstructive, fifth is dissociative. Now we will study pathophysiology, appearance, that is signs and symptoms, examples and treatment of these type of shock. Okay, so hypovolemic, as you already know, there is volume depletion, there will be decreased preload. Cardiac output is decreased, preload is decreased. Okay, due to volume depletion. Volume depletion occurs in hemorrhagic and non-hemorrhagic type of shock. Hemorrhagic, in which blood is lost due to trauma. Non-hemorrhagic is volume loss because of vomiting and diarrhea or other losses. So the appearance or the signs and symptoms in this type of shock are tachycardia in everything, tachycardia, vasoconstriction, narrow pulse pressure, delayed capillary refill time, orthostatic changes, altered mental status, and decreased urine output. In this, we give IV fluid bolus as in every type of shock because of low BP. Second is vasopressors and blood replacement in case of trauma. Cardiogenic shock, there will be decreased cardiac output due to myocardial dysfunction. There is increased afterload and or lack of ventricular filling. This occurs in cases of cardiac dysfunction, as occurs in cardiomyopathy, myocarditis, as in case of inflammatory process, autoimmune diseases, impaired coronary perfusion, acidosis, HIE, in infants, drug dependent lesions. For this, the signs and symptoms are same, but there is cold extremities because of increased afterload and myocardial function is decreased and cardiac output is also decreased. There is narrow pulse pressure, same as above. The respiratory distress will be there, rail scallop rhythm will be there, enlarged liver, cardiomegaly and chest radiograph. The other thing is there is significant difference in BP between upper and lower extremities. In this also we give IV fluid resuscitation, but judiciously, because there is already rail and respiratory distress already present, signs of overload can be there. Inotropic agents are the second line agents to improve contractility, vasodilators to reduce afterload, and management of tachyarrhythmias. Prostaglandin E for infants less than 2 months old having duct dependent lesions, in which we are suspecting duct dependent lesions. Third type of shock is distributive. In this also cardiac output is decreased. Systemic vascular resistance is decreased due to peripheral vasodilatation. There is preload and afterload, both are decreased, and there is redistribution of blood flow away from vital organs, loss of sympathetic outflow. This occurs in sepsis, toxic injection, and anaphylaxis. In case of septic shock, there is warm extremities, pulse pressure will be wide. Tachycardia, vasodilatation, flushed extremities will be there. Pounding pulses, flush, delayed capillary refill. In anaphylaxis, there will be rash, facial swelling, bronchospasm, hypotension. Spinal shock, in case of spinal cord injuries, there will be bradycardia and hypotension. Neurogenic shock, increased ICP will be there. In this, as we all know, the first line agent is IV fluid, second is vasopressors, and in this septic shock, antibiotics need to be administered. If a specific antidote for the toxin is there, we need to administer that. For anaphylaxis, remove triggers, IV fluid, and IM epinephrine is given along with antihistaminics, vasopressors. Spinal cord injuries, same IV fluid and vasoconstrictors need to be given. Obstructive shock occurs in case where there is obstructive process due to which the right ventricle has increased afterload, and due to which there is decreased cardiac output, as occurs in case of tension pneumothorax, pulmonary embolism, and cardiac tamponade. There will be tachycardia, delayed CRT, cool extremities, narrow pulse pressure, distended neck veins, and distant heart sounds, because there is something obstructing the flow of the heart. Anticoagulants need to be administered in pulmonary embolism, drain pericardial effusion, and evacuate pneumothorax. Fifth type of shock is dissociative. In this, high cardiac output failure shock is there, as in case of anemia, due to inadequate oxygen releasing capacity. In distributive and dissociative, the difference is decreased cardiac output and high cardiac output. The only type of shock having high cardiac output failure is dissociative, as in case of anemia, carbon monoxide poisoning, methemoglobinemia, and cyanide. The signs and symptoms will be same: tachycardia, delayed CRT, cool extremities, weakened pulses, pallor, or flushed cheeks. For treatment, we give gradual fluid replacement, blood replacements in case of anemia. For carbon monoxide, methemoglobinemia, and cyanide, oxygen need to be administered, hyperbaric schema, methylene blue, hydroxycobalamin, and cyanide antidote kit need to be administered. Thank you.